shared decision making. Thank you to the ASPS for allowing us to talk about this. It's something I feel very strongly about, and I'm privileged and honored to have these great folks with me on this panel. Once upon a time, I'd tell patients their breast reconstruction options and the associated good job. Turns out I could have been doing better, at least in my opinion. I found shared decision making and it changed my practice forever. So today, hopefully, we're going to give you some info that will, I hope, make you think a little bit if things that you can introduce into your practice to feel the same way. So we're going to start off with Dr. Sbitany. He actually doesn't need an introduction. Come on up, Hani. We only have an hour, so I don't want to take up 20 minutes talking just about your pedigree.
Thank you. All right, well, we'll jump right into it. So my name is Hani Sbitany, and I apologize. It's Monday morning at the meeting now. I've lost my voice to some degree, so if it's so I'm going to talk a little bit about shared decision making, what I envision it to be, and how we've incorporated it into my practice in San Francisco, California, where I work at UCSF Medical Center. This is where I work and live. You can see both my office and my apartment if you really, really squint hard, just to the right of the tower of the Golden Gate Bridge there, and this is my hospital. And it's in this facility at our breast care center where I practice and perform primarily breast reconstruction surgery, where I perform these operations every day. Oncoplastic breast reconstruction for women undergoing partial mastectomy, whole breast reconstruction using prosthetic techniques, nipple-sparing mastectomy, now pre-pectoral going, cancer treatment with post-mastectomy radiation. I also perform autologous reconstruction both in the immediate and delayed fashion. I perform all these techniques, and like we just heard, for a long time I was seeing patients, discussing their disease with them, indicating to them what I thought was the best option, and usually just signing them up when they immediately agreed with me for whatever I recommended they undergo based on how I viewed their treatment course to be. But really, if you look at the data in our current existence in breast reconstruction, we need to be doing better. Right now, and this is a paper from Sloan Kettering a couple of years ago in PRS, this mirrored numbers that I kind of expected, but I'm still about 40% of women undergo breast reconstruction alongside breast cancer treatment. And it's crazy to think that for all of us who live in this age of hyper-awareness of breast reconstruction, live in this age where this is what we do every day, but when only 40% of women undergoing cancer treatment seek breast reconstruction, it indicates the need to do better. And while this is increasing, these numbers are of course, to all of us, still drastically deficient. And part of it is due to lack of access to care. Part of it is due to certain issues around payment for procedures and insurance-based coverage. But a really significant trend driving this low number of breast reconstruction in U.S. women is really a lack of patient awareness or understanding of what the authors of this paper suggest a significant role for patient aids and shared decision making. Because when we offer, and I'll discuss both of these in a minute, but when we offer these situations in our practice, we can almost predictably identify the fact that these percentages will increase. And again, the authors of this study identified the fact that with increasing numbers of options slowly being offered, both tissue-based and implant-based options, we really will need to collaborate with our patients, offer them shared decision-making to make sure that we drive a higher patient satisfaction, better choices on behalf of our patients, and thus a continued increase in the trends of breast reconstruction in the United States. So what is shared decision-making? It's essentially the conversation that happens between a patient. So many of us get ingrained in this world of we walk in, We tell the patient what we think they should have, and they sign up for it, when really it should be a team-based approach. It should be a conversational atmosphere. And this involves sharing information. We don't hide anything from our patients, and really we can't anymore. They can get all the information they truly need off the internet, off social media anyway. So we discuss it with them up front, discuss their uncertainties, their options, the potential pros and cons regarding outcomes, possible complications, really equip them with all the decision they need to be an equal member of their decision-making team alongside us and make the right decision. And this oftentimes, for most of us, including myself and all the panelists, involves structured decision-making aids. It's one thing to just regurgitate your office, but it's another thing to offer them physical decision-making aids that they can look at, they can review after your consultation before they make a decision. They can really equip themselves with all the tools they need to make the right choice. And for us as physicians, it's really important to embrace these concepts of shared decision-making and decision aids, because ultimately informed patients are the happiest patients. None of us want unhappy patients. We know when we occasionally have patients that feel that they could have had better outcomes, how difficult it is for them, for us, for our staff. It's not a pleasant experience for anyone. And when they have the full information and make the right choice, even if the outcomes are not always completely 100% positive, they still take some amount of ownership and happy patients, because they're active participant of the team. And the one thing I never want to hear in my office is, "You never told me about this option," or "I didn't know this was even an option until I heard about it much later on." All right? Those are the phrases that generate unhappy consumers in any industry, and certainly in ours. And we know we have to do better, because we know that unless we employ complete shared decision-making, our patients won't make the highest quality decisions. Clara Lee put together a beautiful study at her institution where over 3 years they looked at patients undergoing post-mastectomy breast reconstruction and the decisions they were making. And they compared what the patient's perceived knowledge was of different procedures to then the selection they made and what they thought they were getting, and how well those two actually lined up to indicate choice that they thought they were making alongside that knowledge really line up. And when they define that as decision quality. And ultimately, they found that only 43% of patients that went through breast reconstruction actually made a high-quality decision based on what they perceived these procedures to be versus the reality, and then how their choice matched up to those ultimate procedures. And you look at the numbers for women who underwent mastectomy alone versus mastectomy with reconstruction, and very low decision quality in both categories, which indicates the need, in my mind and in the mind of the authors, a need for shared decision-making, a need for decision aids to equip patients to make better quality decisions. So what's the value to surgeons and to healthcare providers to adding shared decision-making in their practice? Understand what we're trying to accomplish. As active members of the team, patients need to know what our goals are just as much as we need to know what their goals are. We'll build lasting and trusting relationships with our patients, which will result in better patient satisfaction, better surgeon satisfaction, and ultimately, for most of us, better word of mouth driving patients to our practice. And if you don't do this in your practice right now, it's not a negative. You're not alone. If you look at survey studies such as this one that assess patient understanding, physician understanding, and nursing understanding of what is shared decision making, what are decision aids, everywhere you look inside the parentheses there, low percentages indicating that few of us still in this day and age understand what is shared decision making and what are decision aids. And I don't look at extreme growth potential. Our goal is in the next 5 to 10 years for these percentages to skyrocket so that every patient, every physician, every nurse is part of a shared decision-making team, heavily influenced and aided by decision aids. Because again, we want our patients to learn about their health and understand their health conditions. If one of us has a family member as healthcare providers who needs to undergo a procedure, I've been in this situation, I want to make sure my family member is as well equipped as anyone in the process and understands what they're getting into. And really, it's no different for any of our patients. We want them to understand the pros and the cons and be better prepared to talk with us and collaborate with us to make the right decision. And this is the bottom line. This is what the influence will be on practice. And I'll show you some of the practices and changes we made in a comprehensive breast care team. My medical oncologist, radiation oncologist, breast surgeons, plastic surgeons, everyone involved in the process. When we incorporated shared decision-making and decision collaborative aids, we experienced better patient expectations, improved patient compliance, patients took a more active role in their treatment, lower malpractice rates, higher satisfaction rates, and ultimately better surgical outcomes because of all of those things. The Europeans have been a leader in this model of shared decision-making, and when you look at German patients and their satisfaction with the care they received in different arenas, when shared decision-making was employed in Europe, the satisfaction with care skyrocketed to a very high, statistically significant satisfied. The New England Journal caught on this and wrote an editorial I'd encourage anyone to read in 2012 on shared decision-making. And it's not just for the reconstructive surgeon. Aesthetic plastic surgery is an ideal environment for shared decision-making. If you have patients who are even further invested, potentially because they're paying out of pocket for procedures, this really becomes an obvious choice of an obvious field or an obvious arena in which shared decision-making should be applied. So how do you institute shared decision-making? We'll hear a lot more about this from the next speakers and their experience being a part of this team. But ultimately, it's a multifaceted, multi-stage approach. In order to truly offer comprehensive shared decision-making, I think there's 3 to 4 phases that we can employ that were beautifully laid out in papers like the Asians. Not just inundate them with a ton of information, tell them what you think they should do, and walk out of the room, ideally with a signed consent form. What you really want to be doing is slowly approaching them, offering them not just one choice, but all the choices, discussing with them the pros and cons, a brief discussion, just overview of every single choice, how they differ, and what the risks and benefits are. Justify the choices. Don't make them feel like if they pick one choice, it's better or worse than the other. You can indicate to them what you think you as the professional would offer with your expert decision-making process, but justify all the potential choices they may make. Check their reactions, try to read how they're receiving each of these choices, and oftentimes defer closing the encounter. Don't think about it. And then we go back for a phase called option talk, either later that visit or at a second visit. Check their knowledge, make sure they understand the choices they've been presented with, go through them again, explore what their preference is. What are they leaning towards? What are they considering based on the different types of operations, their lifestyle, how it fits, the recovery fits into their lifestyle, what they perceive to be the harms and benefits of each option. At this point, offer them decision support aids. Give them other sources of information they can use to solidify their choice and summarize all the options. And then at some point, make a decision with them. Not at the first stage, at the third stage. Focus on their preference, elicit their exact preference, make sure it lines up with what they perceive that procedure to be in reality. We instituted this at UCSF a few years ago, and it's done wonders for us. And not only do we go through this stepwise progression as a multidisciplinary unit, but we also offer decision services. We have a support staff that contacts every patient prior to their consultation, goes through their initial questions prior to their consultation, writes them down, and then they come in with us, as you see one of my former colleagues doing here with a patient in our clinic, as was highlighted by the Wall Street Journal, meeting with a patient and a decision support aide who's recording the visit for the patient, but also writing down the patient, the visit, a very brief transcript, and they'll summarize the decision-making process and the consultation for the patient so they have that aid to go home with that day. They'll type it up for them on the fly. They perceive the patient may have had that were and were not answered, so the patient can review them later on. And we do this at the initial consultation before the patient makes a final decision. So they go home with these decision aids in hand, reevaluate the visit, reevaluate their questions, consider the questions that were written down that they may have forgotten to ask, so that they can ask them at a future date. And this has really done wonders for us. It's resulted in all the benefits I showed you earlier, as well as patient advocacy in our center, and increased patient referrals, and ultimately just happier patients. And so that's just kind of a very brief, very broad overview of how we've instituted shared decision-making and really decision aid and decision support services at our facility, and really improved our outcomes and our patient satisfaction. And ultimately, one of the most important things, which is patient advocacy, two of our incredible patient advocates to talk from the first-hand experience, what they've experienced going through this process with shared decision-making. So I don't know if you want to come up and reintroduce them. They probably deserve a true, proper, honorable introduction. Thank you.
Thanks, Hani. That was excellent. So the other half of this conversation, of course, is the patient. So you can't have shared decision making without an equal collaboration with your patient. So we have two phenomenal patient advocates with us today. And the first is Terri Coutee. I'm very honored and privileged to have been her surgeon. She has ended up with her creating her own foundation, Deep Sea Foundation, and she's doing some incredible work in terms of advocacy for all types of breast reconstruction, affecting both women and men throughout all stages of the breast cancer journey, and also prophylactic journey. So without further ado, Terri, come on up. Oh, I'm sorry. Why don't you go for... You want to go next? Okay, I'm sorry. Terri, I've just introduced you, so now you have to come up.
Good morning. Thank you to ASPS for the opportunity to participate in the second patient panel at PSTM. I know I speak for Kristin and myself when expressing our gratitude for being here presenting patient advocates to discuss the important topic of shared decision-making in breast reconstruction. In many respects, we still use the definition for shared decision-making published in 2010 in the British Journal of Medicine. I feel it has evolved over time, but the value of mutual respect and participation is that Dr. Sbitany and Kristin have made some very compelling points as to why you should consider adopting shared decision-making in your practices. I'm going to take it a step further. I guess actually Kristin's going to make her points in a minute. I'm going to take it a step further now, and I'm going to discuss patient advocacy as a potential for you to leverage. I believe it is possible for you to gain more patients, potentially improve your outcomes, and get higher patient satisfaction scores by proactively engaging with the patient advocate community. Isn't it our common goal to improve patient outcomes and satisfaction? I think so. This summarizes how communication can influence your relationships with patients and improve your practice in my eyes. The circle of communication beginning with you. Shared decision-making is what made my plastic surgery experience so successful with deep flap breast reconstruction. Like Kristin, it is so important to me now. I work as a patient advocate so other patients can have the same opportunity I did. About how your patients do. And you want your practice to be successful. Let me begin by sharing how this communication works in my role as a patient advocate. I use social media to get my message out about the importance of shared decision-making. Many of your potential patients feel very strongly about having their voices heard and being part of the treatment decisions. Patients use various social media platforms to obtain information about a procedure or to find a plastic surgeon. The flow of information increased social media, Facebook, Twitter, Instagram. I gather evidence-based information from you. It is shared to my close Facebook group that provides not only research articles, but support for patients considering breast reconstruction. I use Instagram to inspire through photos, share blogs, and educational YouTube videos, many that include ASPS surgeons. I receive private messages on all of the platforms with questions from patients. So all these social media channels include links to the blog I write about my experience of having me. I want other patients to read it so they can be fully informed using a shared decision-making model like I was lucky to have. Think of this as a chain reaction. Let us be your team members to improve your patient relationships based on our training and experience as patients. We've been there, done that. There is no one better for your new patients to talk to than an educated, happy previous patient. Patient advocacy can come in various forms, but all forms add added value to your practice. Advocates like Kristin and me who are engaged daily in our communities. We attend meetings, sit on advisory boards, we seek opportunities for scientific training, we research, we collaborate with other patient advocates, and finally, we seek opportunities to engage with those medical professionals who know we can make a difference for our fellow patients. We like doing it so much we're here today. We fight for the things we believe in. We want a reason to fight for you. There are patient advocates working as individual contributors who have been your patients, but they loved being your patients. Why? In many cases, it was because they felt that they were part of the decision process. You were completely transparent and told them about their risks, possible complications, expected results based on their age, health, body habitus, and you discuss their goals, individual lifestyle. You ask what was important to them, and even about the support system they had available for recovery. You listen to them. Perhaps you even adjusted the surgical plan based on their input, as long as that was what shared decision-making is. There are patients that walk into your office with a wealth of information about the procedure you're going to perform on them. When you complete your thoughtful and comprehensive evaluation, you sit back and let them take their turn. You listen and honor the research they did before they came to see you, or perhaps you gently guide a patient through the process who makes it clear they only came to listen to your expertise on the procedure. That's what shared decision-making is. In all of these examples, the patient has ownership and therefore accountability in the examples of how engaging your patients in shared decision-making can result in a valuable ROI in your practice. There's a third party at work here, and it's the patient advocate. This is truly a team effort. I opened a nonprofit foundation 2 years ago to support women and men going through breast reconstruction. A small part of the mission of the foundation is to provide support when it is needed most. At a time when patients are fearful, lacking resources, or wondering how they will feel after surgery. The need for patient advocates to be committed to helping us here in the growth of my Facebook group called The Journey just in 1 year. The need for support and guidance to understand the value of the shared decision-making experience is growing by word of mouth. I frequently have one-on-one conversations with women who are really struggling with their surgical options. They have children, families, jobs, pets to take care of, exercise classes they want to get back to, and they wonder, will I ever get back to normal, or will I just have to accept a new normal with scars, loss of sensation from the mastectomy, and new feelings at the surgical site? But they really appreciate talking to someone who has walked the walk, especially someone who knows the plastic surgeon that they are considering and what kind of job they do. I always tell them about the philosophy of shared decision-making and how important it is to find a surgeon who practices this. So, some stories. I know a woman who had a second breast cancer diagnosis. At the time of her first diagnosis, she endured a lot. 2 lumpectomies, intense chemotherapy that included adriamycin, the red devil. She was bald, weak, and then concluded 9 months of treatment and surgeries with 6 weeks of daily radiation. So to have a second diagnosis 12 years later wiped her out emotionally and physically. She is what some of your colleagues might consider to be a well-educated and savvy consumer. She chose her reconstructive surgeon wisely after doing her homework. I'm going to tell you a little bit more about her later and how her shared decision-making experience turned out. This next story, quite frankly, blew me away. Why? Because it made me realize. I spoke to a woman in late August, just of this year. She found me through the blog that I write and emailed me through the contact information on the website. She told me she was a physician who was just diagnosed again. But she wanted to have a completely private conversation, one-on-one, with someone who chose a surgeon, was happy with her results and could tell me about her recovery from DIEP. I want you to remember something she told me. In her email, she voiced her concern about Yelp or a plastic surgeon's website for public ratings. She told me she wanted to hear from a patient. She wanted to hear from a patient of the physician she intended to go to for a consult. She wanted to talk to someone who engaged in the shared decision-making experience. I told her about my experience and how I had traveled 800 miles to find my just right plastic surgeon. She informed me that travel was likely off the table for her due to her own personal circumstances. I knew where she lived, and I said to her, you know, I think I've spoken to a woman who has gone to the plastic surgeon you want to go see and are asking, would you like me to see if I can connect you to? I was sitting in front of my computer at the time of our conversation, and I quickly typed a private message to the woman I told the physician I'd connect her with. And fortunately, the woman was online and responded immediately to my message and agreed to share her successful experience. I connected the two women. Less than an hour later, I received an email from the physician who had been diagnosed, and she thanked me, telling me she was now comfortable going forward with her decision to go to that physician. We use the phrase patience. It's a phrase I believe we should all be putting in our plastic surgery vocabulary, and best of all, put it into practice. As patient advocates, we are your connectors. When we have successful shared decision-making experiences with our plastic surgeons, we want that for other patients. Let me conclude by circling back to the story of the woman I spoke of earlier. The woman who had a second breast cancer diagnosis did her due diligence to find a surgeon she felt most comfortable performing her breast reconstruction. The woman I speak of is me. Embrace the concept of shared decision-making from one of your colleagues, Dr. Minas Chrysopoulo. So thank you, kind sir. Dr. C, and to all of you who made the decision to attend our session this morning, I will continue to speak about shared decision-making because it made a difference in my outcomes. And I know there are patients out there, your future patients, who want the same experience. We know there are challenges putting the shared decision-making model into practice. May we not let those challenges stop us from having this conversation. The conversation about shared decision-making despite those challenges. Thank you to ASPS for this opportunity. I hope to see you all in San Diego, if not before. Thank you.
Thanks, Terri. We're also extremely fortunate to have Kristin Litz with us, who has flown from San Francisco just to be here. She's also a breast cancer survivor, and for over 20 years she has helped raise millions of dollars for breast cancer research, education, and prevention. She served with Bright Pink, where she educates women between the ages of 18 and 45 on the basics of breast cancer and ovarian cancer. And she's also And she's also vice chair of the board of directors with the HERS Breast Cancer Foundation. So welcome. Come on up.
Good morning. Thank you for taking the time to be here. The other panel members and I appreciate your desire to learn about shared decision-making from the perspective of both medical professionals and patient advocates. In addition, I appreciate the conscious decision you made to be here with us. Speaking of, to the days that were spent learning our ABCs, taking afternoon naps, and watching cartoons. Please raise your hand if when you were younger, you wanted to be a plastic surgeon when you grew up. Those of you that did made a conscious decision to follow your dreams. You attended more years of school than I did, and today you are amazing surgeons that can change the lives of people. You made the decision. When I was younger, being a fashion designer was at the top of my list. However, life does not always go as planned. Before I tell you about my education, I would like you to take a moment to register your first impression of me as I walked up to the podium to speak. I'm going to come back to the reason about if my degree has anything to do with fashion. The answer is no. My degree is in mathematics, secondary education, and I have a master's in information technology. The decision to get these degrees was all mine. We are all guilty of making first impressions. It's human nature. The problem comes when we are not flexible enough to let the first impression go or change. Remember your first impression of me? Has it changed a little now that you know more about me and my education? I'm going to assume that all of us can agree that the education we have came from a conscious decision and after looking at other choices and options. Into account that looking at all the options available to us that meet our criteria, and after knowing more about the complete picture and what all is involved is a good way to make a decision. In life sometimes we are presented with situations where no decision was made. This is the case with breast cancer. I had no say in being diagnosed with breast cancer. No one I know chooses or wants to get cancer, yet it happens. And how an individual decides to handle their situation can change their life. It did mine. A little more than 3 years ago, I was contacted by my local hospital to be in a video. I had finished my cancer treatment on tamoxifen, wearing a prosthetic, been through. Having been treated for breast cancer was a secret in certain circles. The hospital asked if I would talk openly about my breast cancer, my nurse navigator, and her importance in my care. My response was to ask if I could think about it and get back to them the following day. This might not seem like a big decision, but it was because it meant strangers would find out my secret. My brain was screaming no way, but my heart was not sitting well with this answer. I needed some advice. I messaged 2 friends. My gal pal gave the generic, do what your heart says answer. My childhood classmate replied, what would your mother say? I will tell you. So I did say yes, and I became the woman in the video. Then I was the woman in the newspaper. It was the beginning of my speaking out and sharing my journey with cancer. I am here today because since that day, I constantly remind myself, it's not about me. It's about my ability to educate, advocate, communicate, to keep one person from going through what I've been through, and because I like to see others succeed. This is what I want to help you do. Until recently, I I did not realize that years ago I had an amazing individual teach me all about shared decision making and how to be an advocate. In October of 2003, I received a phone call from my family that my mother was in burst brain aneurysms. Before I reached Colorado, the aneurysms had been coiled and my mother was in a coma. I remember the doctor's visits later that day. 2 neurosurgeons entered her room, and just like you did when I walked up to the podium to speak to you, I unconsciously made a first impression of them. I too, that day in her ICU room, took stock of the doctors standing in front of us. The younger one in the suit with the polished shoes, perfectly groomed, standing to the left of the older doctor in his jeans, tennis shoes, and holding a worn leather medical bag. The younger one began to speak. He was good. Used a bunch of big words, talked mainly to my father, and completely over the heads of my sisters and I. Thank goodness happy when he finished, because not understanding left me feeling very uncertain and uncomfortable about my mother's prognosis. Then he stopped, and the other doctor in the jeans and tennis shoes began to speak. He addressed the whole family. He spoke using terms and language I understood. I am sure he repeated much of what the first doctor stated. The difference was he was speaking to me at my level of understanding and treating me as an equal. He shared what was happening and his thoughts on Mom's prognosis. He took the time to make sure that all of us understood the situation. My younger sister and I took away different messages that day. My sister heard that my mother was going to die. An individual was watching over her and part of her team of doctors. 53 days after my mother fell into a coma on her 66th birthday, she woke up. By this time I had returned to California and, like others, was reading the weekly status my father posted online to keep everyone up to date. My father took a very active role in my mother's recovery and rehabilitation. Being an engineer, he looks at things with logic more than emotion. He worked with her neurologist in determining the pressure adjustments to her shunt and in determining which medications seemed to be making positive impacts and those that didn't. My father was her 18-hour-a-day caregiver. It was a team effort during doctor's visits and while at home. He became her voice, her advocate. In my mind, he was being dad and taking care of the woman he loved so dearly, my mother, beat many of the odds that were stacked against her from the outset. If she had not fallen and hit her head in January of 2007, I think she would still be here with us today. Why does this matter and why should you care? Because breast reconstruction is different from other surgery and the perfect place to begin practicing shared decision making. As I already mentioned, the decision to get breast cancer was not one that I made and not one that I was prepared for when I got the news. The news introduced me to a multifaceted disease. Breast cancer is emotional, mental, and physical. The most emotional components for me and wondering whether I'll lose my hair, the what ifs of the disease. Then there's the mental aspect. For me, these are the hardest and stay with me. The why me of the disease. Did I drink too much? Did I eat too much red meat? Did I not exercise enough? And the big one, will it come back? Then there's the part you all know too well, the physical. I took before pictures of my breast. This was the first time I was having surgery to remove something I saw every day, my right breast. Let's go back to that first impression. I hope that you have changed yours, some, while I have been up here talking. I hope you feel like you know me more, and we have started to develop a relationship where trust has been established. I can Google you to find out all sorts of patient reviews, even if you've been sued. For you to find out about me, I must actively share things about me with you, especially the really important things, in order for this relationship to work for both of us. Your first responsibility in this relationship is to listen and consider what I have to say, my situation, my goals, what's important to me. Then it will be your turn to tell me what I need to know about the surgeries that are available to me, the pros and cons, the good parts and the bad, because in many cases I've already been through the bad and I want to know it all. If you do this, then I am able to make a conscious decision that we both actively contributed to. Do this and you ask to ensure that I'm a great patient and do well. When I am part of the decision, I know that we are now a team with a common goal and shared expectations. If you uphold your part and my surgery leaves me as expected, we both win. What does winning mean when you work with a patient advocate? That your name and your work will be shared over and over again because your work makes us proud and feel normal, or at least as normal as possible. As advocates, we talk and talk and talk to any and everyone that will listen via social media, email, face-to-face, and during presentations. We are walking billboards, resources, and living proof of life after cancer. As advocates, we donate our time. We can be your unpaid Yelp and Google rating, because unlike picking out a restaurant or a spa to get fillers, an advocate has often stood in the same shoes as your new patient and is able to share their personal story, the good, the bad, and the final outcome. This is possible because for us, the return on our investment is in karma points, not dollars. Advocates of all types fight for the things we believe in, monthly, daily, and sometimes even hourly. Having doctors that believe, support, and practice shared decision-making give us a reason to fight for you. The panel and I thank you for your time and attention.
All right, well, that was great. I'd like just to summarize with a few points and hopefully give you some more pointers in terms of getting started in your own practices. Important disclosure is that I'm the founder and co-creator of the Breast Advocate app, which is a shared decision-making app. The other important thing about this disclosure is that I couldn't have done it without the folks on this panel, and also many others who put in a lot of work. Some of you are in the audience, so thank you. The focus is on breast reconstruction. That's pretty much all we do. Our core service really is tissue-based reconstruction, but we offer the whole gamut of reconstructive options. Most of us grew up with a paternalistic approach in terms of decision-making in our training. That's what we saw. It's what we saw our seniors and our mentors do. But what we're talking about here really is a two-way street in terms of the communication. So the Venn diagram shows really the sweet spot, which is in the middle when you take into account what you know, your expertise. You don't have to, in terms of your expertise, and the patient factors, the various patient factors, and evidence-based medicine. You've heard some great studies from Hani. Patients are conflicted before they even get to your office, especially if they've had a breast cancer diagnosis. So 40% of breast cancer patients do not fulfill their preferred role in their treatment decision. That's been associated with decisional conflict, delaying the beginning of their treatment, regret, lower quality of life, and of course, poor patient satisfaction. In terms of breast reconstruction specifically, only 43% of reconstruction decision, and I couldn't agree more. We've got to be able to do better than this. And I think everyone would agree with that. You've also got the rise of patient advocacy, and this can't be ignored, and it's certainly not going away. And it's an excellent thing because it can make us all better. You've got self-advocates, and then you've got the organized advocates, non-profit, and even professional advocates. And then when you add the rise of social media, especially in this country, you've got 78% of Americans on social media platform, each of them using social media for an average of 2.5 hours a day. You're not going to get away from this. Education, lower anxiety, less decisional conflict, improvement in buy-in and setting of appropriate expectations, and of course, improved patient outcomes. And most of those benefits, not only for the patient, but they directly impact you in a positive way. So what are the barriers? What do people say? Why wouldn't they practice this? Isn't this a no-brainer? I think it is, but why wouldn't you? Well, it takes so long. You got to talk about everything, and learn about them. It's harder. It's not part of my routine. It's something new. Change is work. And situation. So some of us are taking it upon ourselves to decide for the patient that they can't interact with you to allow shared decision making. So I reject that. And then there's a financial disincentive that shared decision making is more compatible with outcomes-based reimbursement and not the type of reimbursement that we have, especially in this country. I don't think that needs to be the case at all, and I think actually not practicing shared decision making can potentially hurt your practice more than being driven by financial incentives. Stands to reason. So how do you get started? Let's say you buy into this concept, so take what we're giving you here and adapt it for you. We don't all have the same practices. We don't all practice the same reconstructive options. We don't all offer every option. Your office may work different to mine. I bet it does. That's okay. Modify your office schedule initially. Not really because you have to, because shared decision making, when done properly, doesn't have to be inefficient, even though it sounds as though it would be, because there's more effort and more conversation. My consultation times are the same as they've always been now. You can't do this without your team. Everyone needs to be on board. Everyone who touches the patient needs to buy in. And if you want to focus and foster patient advocacy, which will help you in terms of word of mouth and help build your practice. We've incorporated decision aids like Hani was talking about. We have a video that goes through all the options. It's the same video that's on our website. It's the same video that plays in a semi-private area in our lobby. We incorporate that in a pre-consultation email that all our patients get. The same email gives them access to our patient portal. And now we're also incorporating the patient advocate app, so patients can actually get to grips with and explore shared decision making even before the patient comes in. It's actually making the consultations even shorter. And then when they get to the office, they also get a patient booklet that's another form of basically summarizing all the same information. A little bit about the app. I'm really very proud of this. It's a shared decision-making app for breast cancer surgery and breast reconstruction for anyone touched by breast cancer or at high risk. Also covers males. Men get breast cancer too. Covers stage 4 patients. It really covers everyone. It was co-created by multiple breast cancer specialists around. Download it. It's available iOS and Android. If you feel you can make it better, please contact me. This isn't practice specific. It's not for my practice. It's for everyone. If you feel you can make it better, please get in touch. And also, if you've got any ideas about corporate sponsorship, I'd really appreciate it. This share approach is something that I used as a guide when I got going, and it was really very useful. So SHARE stands for seek, help, assess, reach, evaluate. So the first step, you basically gauge what level of conversation the patient wants and what they can advocate deliberation in every interaction or for every decision. So the degree of autonomy that the patient wants is part of the process. So when I said earlier that one of those barriers was patient characteristics, and I mentioned that I reject that. The reason is a patient telling you, Doc, I really just want you to tell me what you think I should do. The fact that you're asking them and they're telling you that's still shared decision making. They're just telling you they're not in a position right now to take on that autonomy because they've got stuff vision. You're not deciding for them. I think that's a very important point. So step 2, explore the options. They've seen the video. I say, what do you think of the video? Very open-ended question. And then they guide you where they want to go. Some of them, obviously, I mentioned our practice is heavy on autologous reconstruction. Some of them start off and they say, well, I'm here because I really don't want implants. So they take stuff off the table. And you use your aids to set the stage and save you time. And then as you move on through the options, risks, discuss all that like we've talked about, then you've really got to make a concerted effort to ask about them and make sure that they volunteer the information, give you the information you need. Do they realize they're going to be numb probably after a mastectomy? How do they feel about sensation? How do they feel about the nipple areolar complex? What do they like to do? What's their work? What's their support structure? And then you reach the decision together. They're bought in. They're going to be more compliant now. They have skin in the game. They're going to be happier, even if they have a complication. And then you evaluate. Is this reasonable? The other thing I'm not saying is shared decision making and to tell you what to do. So if it's unreasonable, you're just going to say no. And here's why this is unreasonable. So some summary points for you. Patients may hold a view that one treatment option fits them and their lifestyle better than another. And that view may be different to yours. And that's okay. Shared decision making recognizes the patient's right to make these decisions, ensuring they are fully informed about the options that they're facing. And the main goal of shared decision is not to force patients to be autonomous if they don't want to be, but to allow them the That's the first step. The three most often reported facilitators to getting going in shared decision making. It's recognizing the positive impact you're having on your patient's outcomes and their entire process, and the positive impact it has on the clinical process and your practice. And you've heard about all the benefits several times today. The main thing, motivation. So the next step is just deciding to take that first step. So hopefully today you've heard a few things that you'll take away, you'll think about things, and you'll consider introducing shared decision making into your practices. Thanks very much. Any questions? So I would like to ask Hani a question. I think this is really important. What do you tell physicians who say, share decision making, discuss all the options, I don't offer all the options, so I'm going to lose business if it sounds good, but I have to make a living.
Yeah. It's a tough situation because we're all, in addition to serving our patients, running a business, and nobody likes to lose business because they may not offer the entire range of options a patient may be interested in. But I think we're in a day and age now where the worst thing you can do is hide options from on the internet. They'll hear about them on social media, and then they'll be really, really unhappy. And ideally, and most commonly, although not ideal, they may find out and be unhappy after you've provided a service to them that they realize in hindsight they did not want. So I think the worst way for us as surgeons to think is, well, if I don't tell them about options I don't offer, I'll have a more robust business, I'll make a little extra money, and in the long run, it's not really going to matter, because the reality is it will matter, and they will find out, and they will be unhappy. And you may make a little bit of extra money up front or generate a little business up front, but in the long term, I really truly think that'll end up hurting your practice, especially with patient reviews. For example, take breast reconstruction. There's a lot of surgeons out there who, unlike you, are not specialty trained in microsurgery. So they may not offer autologous reconstruction to their patients. They may not even discuss it with their breast cancer patients. They might say, you know what, implants are the way to go, and not even broach the subject of an autologous option because they don't perform it. But there's ways around that. I think it's something, we're in a day and age now where it's still incumbent upon the surgeon to discuss all the options and to be upfront with the patient and say, listen, I don't myself offer the autologous approach, and I can do one of two things. I can either refer you to someone who does it. Ultimately, that'll generate a reputation for you as someone who's ethical and honest and will increase your practice long term. Or what a lot of surgeons do is, I do autologous reconstruction with another very talented microsurgeon down the street. I know a lot of surgeons who are finding ways to extend their practice by performing co-surgery with surgeons in their community, and so that they can still offer the entire breadth of reconstruction in their practice. So there's ways around it, but the idea of I don't discuss options that I don't offer personally in my practice, I think is a dangerous one, and one that we really have to work hard to avoid in our practices.
Yeah, I couldn't agree more, because ultimately the patient's going to find out what they want to find out anyway, so it's best coming from you. The collaborative approach is, I've seen that, it works very well, and everyone's happy because they stick to their wheelhouse, and surgically you're comfortable with the options you're offering, and then plus you're increasing this into appealing. Okay, I think we're going to wrap it up. Thanks everyone for coming, really appreciate it.
Yeah, thank you.
Thank you.